Hello everyone, my name is TremblyC. I'm a fourth year medical student here at Dawson and Sudbury, and today I'll be talking to you about our project entitled Approach to Burn Treatment in the Rural Emergency Department. We have no relationships with for-profit organizations, and we have not received any financial support. So we really wanted to do this project to outline a simplified approach to the assessment and initial management of patients with burns in the rural emerge. We proposed some mnemonics to make it easier for everyone to remember. We did so by compiling current local guidelines with the assistance of Dr. Sanjay Azad, who's a staff plastic surgeon, to develop this systematic approach. We really want to do this because obviously sometimes the care of patients varies on the location, the provider training, so we wanted to make sure that it was simple for everyone. So here on the left, we have the pre-hospital care. So essentially the main premise here is to start IV fluids at 125 mils per hour, ringer's lactate, and you can calculate this more specifically down the line, maintain a warm environment, and provide pain control most importantly. And then once you arrive at EAD, we have the primary survey, which is the ABCDE mnemonic. So support the airway and paying special attention to the facial and neck burns. In terms of breathing, auscultate the lungs, put them on monitors, and help them with oxygen. In terms of circulation, locate and mark the peripheral pulses early and monitor hemodynamics, so blood pressure, pulse rate, skin color, and pulse oximetry. In terms of disability, you can perform a GCS score and perform a neuro exam if you can, but we understand that it's difficult in these stressful situations, and then try to determine the cause of injury. In terms of exposure, so completely expose the patient, examine them closely, and then maintain a warm environment. In terms of flight or transport, consider arranging that early so that you can expedite the process if needed. For the secondary survey, we have the anthropometric characteristics for the pre-burn weight if you can. You can run some simple blood work as well to figure out if they have any metabolic disturbances and if they need a blood and type screen. Here you can calculate the percent total burn surface area, and this is only for second and third degree burns. The degree of the burn, which can be more thoroughly assessed in this next step in the burn assessment, so determining the depth, whether it's partial or full thickness, any blistering, the color of the burns, if it's blanchable or non-blanchable, and if it's painful or non-painful. And then you can more precisely calculate the percentage of TBSA using the rule of nines chart where it identifies the percentage of body parts involved in a burn. The rule of palms, it's important to use the patient's hand, which represents 1% of the whole body, and then using the more accurate but more time-consuming Lund and Browder chart as well to calculate this. So in terms of burn management, or the PIDGOT acronym as we call it, so pain management is obviously the most important. So you can use things such as ketamine, you can use things such as midazolam for anxiety, and then obviously opioids also have a place in this as well. In terms of IV fluids, so here is where you can really calculate the flow rates for adults, children of varying sizes. In terms of deroofing the blisters, it's important to deroof the large painful ones that overlie the joints of the creases, and allow the other ones to just spontaneously drain, and to never forget pain management during this process. Dress the wounds, keeping the heat and fluids in is obviously very important, and then also considering the other levels of care, so rechecking in about the transfer if needed, and then tetanus is always a good thing. So certain criteria that have been outlined by the advanced burn life support criteria. So if it's a partial thickness burn with more than 10% TBSA, any burns involving the face, hands, feet, genitals, perineum, or major joints, any third degree burns of any age, any electrical or chemical burns, any inhalation injuries, any patients with pre-existing medical conditions that could complicate the care, any patients with burns and potentially contaminant fractures or trauma that will potentially increase the mortality, and then children with burns in hospitals with the qualified personnel, and then finally, if a burn injury, the patients who have who may need complex interventions. So if you fit any of this criteria, refer to your nearest burn center, cover the wounds at their discretion, and then keep the patient warm. And then if not, if they need to be admitted, transition from the ED management to the admission process and continue pain management. Think of any infections that could be happening, treat them, and consider the whole picture. And if they don't need to be admitted, continue the pain management, continue to debride the blisters once you have some time. Wash the burns with warm saline and soap or dilute chlorhexidine, and dress the wounds and apply any secondary dressings that are needed, and then arrange any dressing changes. Thank you so much for your time. I really appreciate it.